Hello and welcome to our presentation for the Congress on Evolutionary Computation 2021. The title of our work is Probabilistic Fitting of Glucose Models with Real-Coded Genetic Algorithms. This is a joint collaboration between two universities from Spain. On one hand, we have Complutense University of Madrid and the researchers Cervigón, Velasco and Hidalgo, and on the other hand we have the Technic University of Valencia and the researchers Burgos Simón and Villanueva. The focus of our research is type 1 diabetes mellitus. In this disease, the pancreas of the patients cannot produce enough insulin, so their cells cannot absorb the glucose that is present in the bloodstream. This way, the level of glucose in the blood increases, and this can lead to several dangerous complications. So the only therapy for these patients is to inject artificial insulin. And for doing so, they need to calculate very precisely the amount of artificial insulin to inject. So our main goal is to help in this task to type 1 diabetes patients by making an accurate prediction of future blood glucose levels. And for doing so, we try to use only historical data from the patient, which includes glucose, past glucose levels, past number of grams of carbohydrates that the patient have eaten, and the past amount of insulin that the patient has injected. Here we can see the whole workflow of our proposal. It has several steps that we are going to see. Here, the first half of the workflow, in which we include the gathering of data from real patients using a continuous glucose monitor. This data is going to be augmented adding white Gaussian noise, and this way we are going to fit a minimal model, which is a set of equations that describes the interaction between glucose and insulin, and these equations with a lot of parameters are going to be fitted using a genetic algorithm, are going to be fitted to the real data using this genetic algorithm. So the data that we are going to use is data from 4 real patients that has used this continuous glucose monitor system, the Freestyle Libre, and an insulin pump that the patients were strapped to their body. This gives us glucose levels samples every 5 minutes, and we have 5 complete days for each patient. In order to have more data available, we are going to augment this data set by adding white Gaussian noise. This is an example of one real glucose time series and 30 synthetic or artificial glucose time series generated by adding Gaussian noise to the original time series. So with all this data, we are going to fit the minimal model using a genetic algorithm. Here we have the minimal model, which is a set of equations with different parameters that, for instance, we have the glucose absorption, the insulin action, insulin sensitivity, ingested carbohydrates, glucose effectiveness, insulin injected. So we have 50 different parameters that need to be fitted to the real data or the data from the real diabetic patient. So the model fitting is achieved using a genetic algorithm that we have code in MATLAB with the real coding of individuals or solutions using these 50 values that correspond with the 50 parameters of the minimal model. These are the parameters for the genetic algorithm. And we have tried to make a more finer tuning of the algorithm, and we have divided the day into 12 sections or time slots. Each of these time slots has 2 hours. This way, we have for 4 of these 50 parameters, we have more precisely values, and we are allowing to these parameters to vary depending on the time of the day. We have the different values in which the algorithm make the search between the lower and these lower and upper values. The fitness function that we have used is the mean square error. This way we have something like the Euclidean distance between the predicted time series and the real data time series. So the second half of our workflow that compose the probabilistic fitting step, the production of different ensembles of models, and the final phase of the prediction and analysis of this prediction. So the probabilistic fitting technique will produce an ensemble of models, 12 ensembles of models, one for each time slot of the day, and each ensemble of models will have between 30 and 50 models. The training and testing phases has been carried out using the cross-validation scheme. So why the probabilistic fitting? Here we have an example of the output of the previous step, the model fitting using the genetic algorithm, and we can see here that the fitting is not enough accurate. So we are not satisfied with this result, and this is the reason why we decide to extend this step, adding a probabilistic fitting step. In the probabilistic fitting, we resample each glucose value using a Gaussian distribution with a standard deviation of 5%. And here we can see that this way we obtain a much more accurate description of the behavior and trends of the glucose time series of the patient. And now the final prediction step. But first we need to explain which is the Parker's grid analysis. In the Parker's grid analysis, which is usually employed by the medical doctors and technicians in this field, in this graph we have in the horizontal axis the real values, the real glucose values, and in the vertical axis we have the predicted values. And you can see that the graph is divided in 5 different zones that we have here filled with different colors. In green, in dark green and light green, we have the A and B zones in which if the predicted values fall here, this is not going to produce a different treatment for the patient. So this is the zone in which it is acceptable to fall the predictions. And in the C, D, and E zones, we have, in the C zone, we have a necessary treatment for the patients. And in the D and E zones, we have a dangerous treatment for the patient, because we are changing or really misinterpreting the situation of the patient. And we can't produce a treatment for hypoglycemia or for hyperglycemia when it is the other way around. Hypoglycemia are glucose values below a healthy range, and hyperglycemia are glucose values above the healthy range for the patient. So in the D and E zones, we are predicting hypoglycemia when the patient is in hyperglycemia, or we are predicting hyperglycemia when the patient is really in hypoglycemia. So the treatment for the patient is what the patient needs is the opposite of what we are predicting. And we have trained the models using 4 days of the 5 that we have, and we have test in the other day the prediction of the models. We have employed the cross-validation, so we have repeated this 5 times using a different day for testing the models and the other 4 days for training the models. Here we have an example of the Parkes error grid for patient 1, 4 days predictions for patient 1. In this case, we can see that our technique gives predictions that fall in the majority of the points in zones A and B. Here, zone A and B, and here, all zones A and B, except this point that falls here in the D zone. This is a really excellent result for patient 1, but it's not the case, for instance, for patient 4, which has a similar behavior to patient 1. But in this case, for patient 4, we have a large amount of points that falls in zone C. Again, for patients 2 and 3 that has similar behaviors, also we have a large amount of points in zone C and some of them in zone D. So we can see that the result of our strategy varies for similar patient behaviors and for different patient behaviors. So this seems to suggest the need to include latent factors in the models. For some patients, this 12 time slot or 12 time division of the day seems to be enough, but not for the other patients. So, summarizing what we have seen, we have presented a strategy for a complete day, for a 24-hour time horizon, forecasting horizon for blood glucose levels in patients with type 1 diabetes mellitus. And our proposal has a workflow with several stages. the main steps are that we have we have augmented the available data using the data augmentation technique that employs white Gaussian noise. We have divided the day into 12 time slots with and we are using a different ensemble of models for these 12 time zones. We have fitted a minimal model using a genetic algorithm and the real data from each of the patients. And all these results are finally, again, finer tuned using a probabilistic fitting. The training and test of the models has been achieved using a k-fold cross-validation technique, and the main conclusions that we have obtained is that this technique or this time division seems to be enough for some patients, but not for other patients. Perhaps other patients needs more time slots, or perhaps they need that these time slots are have a flexible amount of time, perhaps different sites, different time slot sites. Okay, and with this we finish our presentation. Thank you very much.